waiting for everyone to get started. We have another couple exciting seminars that'll be coming up. So here's our dates, just to save the date. And we'll get the titles for those once they become available, but hopefully you'll be able to join us for those as well. And for today, really looking forward to hearing Hanna's talk. It will be a Theragnostic 3D ultrasound imaging system for high resolution image guided therapy. Hanna's been doing a lot of really exciting work, and really excited to have her as one of our PHIND Phillips Fellows. A little bit about Hanna. She received a BS and MS in physics from ESPCI Paris in France, as well as an MS in engineering and management from Mainz Paris School. She graduated with her PhD in 2020 under the supervision of Michael Tanter in the physics for medicine laboratory in Paris, France. Her work focused on SVT and matrix approaches for aberration correction and sound speed quantification and ultrafast ultrasound imaging. She joined the Ferrara lab in 2021, where she's working on the issue of deep high resolution imaging in 3 dimensions and in complex and aberrated media. She is also exploring novel array designs to provide a single tool for both ultrasound mediated therapy and imaging. So really looking forward to this update on your project, Hanna, and please take it away when you're ready.
So hello, everyone. Thank you very much, Ryan, for the introduction. So my name is Hanna, and I'm a postdoctoral fellow in Cathy Ferrara's laboratory. I arrived in Stanford about a year ago. And today I'm very happy to present you my work on the Theragnostic 3D ultrasound imaging system for high resolution image guided therapy. So the outline of my talk will consist of first presenting you the current challenges in clinical ultrasound imaging, then proving that the way forward, that is what we think is the large aperture arrays. And then I will develop the novel 3D ultrasound Theragnostic system that we are currently developing. And I will finish my presentation with prospects of large array use in clinical ultrasound imaging. So first, the challenges that we are facing in ultrasound imaging to translate it wider to the clinic. As most of you may know, ultrasound imaging relies on the use of a probe that is called also a transducer, an array of transducers made of piezoelectric transducers. So they will convert electric signal into a pressure wave that is going to propagate in biological tissues. And it will get reflected, for example, on an organ and create a backscattered wave that once received on the array will lead to the image that we're generally looking at, that is the B mode, but we can also do some more complex image. We will discuss that later. So a pressure wave transmitted, backscattered, and we can create an image out of it. What is really powerful about ultrasound imaging is that it is non-invasive. If we compare it to biopsy as a diagnostic tool, it's a main advantage. Also, it is accessible compared, for example, to MRI. Ultrasound is much more accessible. Compared to X-ray, it is not irradiant. And compared to optics, it has a deep penetration. Also, a powerful asset of ultrasound imaging arose around 10, 15 years ago in the community of ultrasound imaging. It is ultrafast imaging. So there is a method, an imaging method that we call the conventional ultrasound imaging that consists in sending focused beams. So, sorry, I'm using the laser pointer. Focused beams, you see that will focus line per line, and the beam is going to be translated all along the transducer laterally. It's called line per line imaging. And it leads to images at a rate of 50 per second with a reasonable image quality. And the idea came to use a single transmission to illuminate all the medium at once, and also use the whole transducer array compared to focus beam. Here now we use the whole, both in emission and in reception. So what happens here is that instead of having as many transmit as number of elements, we only need one transmit, receive events to create an image. Obviously, it's going to be much faster, up to 10,000 images per second, sorry. But the quality is strongly degraded. The solution for that is to combine numerous plane waves. The number n will be able to be optimized. And when we combine these, basically we do exactly that, but with different steering angles, and we sum the output images. We retrieve a very good image quality, and we see that we came from tens of images per second now to thousands of images per second. That allowed the ultrasound community really to unveil novel physiological phenomena happening on very, very short time scale. And this is how was born what we call ultrafast localization microscopy, or ultrasound so-called super resolution. Here you see images of functional ultrasound. These technologies were really allowed and are quite developed in 2D. They were really allowed by ultrafast imaging. So with all these qualities, we saw that compared to other imaging modalities and this ultrafast capability, ultrasound imaging is still facing some major challenges to be translated to the clinics more. Indeed, if we look at the example of surgical guidance and what ultrasound is capable of compared to CT or MRI, we see that we really lack performance to locate, for example, the area where we're going to punction. And the need here is to have a better resolution, a high contrast, a large field of view, if possible, some volumetric imaging, but also fast imaging. Compared to an MRI, we're not going to image the whole body of the patient or a whole section of the patient. We only have a quite smaller array, so we need to be able to image in real time. So the physician is going to see the image in real time, and when he moves, he has real-time actualization of the images. So really, what we want to do here is develop a system that will allow to visualize the anatomy and the therapeutic mechanism at a new spatiotemporal resolution level. And we deeply think that large aperture arrays are the way forward to do so. Let me explain why. If we look at an array of transducers, so it's really a schematic representation, but of large aperture L, and we consider a point target at a depth Z, then the spatial resolution is going to be the width of this target on the image, and it is proportional to lambda Z over L, where lambda is the transmitted wavelength. What happens here is that you can see on the formula, if we increase L, then this width decreases, which means a better resolution. If the point target is smaller, the resolution and the image quality is better. So that's one thing. But also, if we have an aperture L that is quite small and we increase this, then the field of view is automatically larger. And if we want to image, I don't know, a structure that is placed where my pointer is, we see that if we had the green array, we would need a very high capacity of steering to reach that point. If we have the red array, we don't need much steering. We will reach it even with the first plane wave, as I showed. The 0-degree angle will image this area. So two things with large arrays: better resolution, wider field of view. But this does come with a need of more channels. It's going to be larger arrays, so more elements, more data, and more channels on the scanner to drive these data. We are very lucky here in Stanford, in the FERA laboratory, to have this system, and not many teams in the world have it. So that's why I want to insist we are really lucky and we need to make the most out of it. So it's a Verasonic Vantage scanner system of 1024 channels. Actually, it is 4 individual Vantage 256 channel systems that are mounted together. Each of them has its own host computer, and one is elected the primary system, and the other are considered as the secondary system. The scanner is the gray box, is going to be able to transmit and receive And the host computer is going to handle all the data transfer part and data processing too. So the primary system, the Theragnostic system, sorry, has the capability of transmitting ultrafast. That means the pulse repetition is going to go up to 5 kilohertz. We can send up to 5,000 transmission per second at the depth we're considering. And the host computers, they're all equipped with GPUs and large memory that will allow strong parallelization of algorithm. I will come back on that. So the primary system will drive the other one on all the clock and synchronization events. And then all the host computers will transfer back the data to the main system. So now that we have the scanner, let's consider the geometries. And in our lab, we have mostly right now 3 geometries that we are looking at. First, it's a wide phase array. So a large array with quite small elements and a pretty low central frequency. Then a ring array that is an ensemble of commercial array, 8 commercial linear arrays that are clinical arrays, actually Philips, that are mounted together on a 3D structure and will allow imaging of the whole structure surrounded by arrays. And then a 2-dimensional array that will allow 3D imaging. So briefly, the wide phase array, it exactly does what we just saw considering enlarging the width. Indeed, if we compare a 96 element phase array to a 384 element phase array, we see what we expected, a better resolution. You see, if you look here, the point targets are smaller and with a better resolution on this side and a wider field of view. We can image this area here that we didn't reach with the 96 element array. So it holds its promises, and some very interesting work can be done and is being pursued on this kind of array. Also, the ring array, so it allows, as I said, an image with insonification all around the tissue that is imaged. So really, if we look here, it's a hand that is poured into the water bath, and you can have in real time an image of the structure. The water bath is one constraint on this system, and it will narrow a bit the applications, the range of applications that are allowed, but it is mostly intended for now for breast imaging. But here today, I would like to talk to you about the design of and how to drive and to treat the data for a 2-dimensional array, for which we have 2 principal objectives. The first one being to perform high resolution 3-dimensional imaging, and the second one to perform ultrasound guided microbubble based therapy. So that's why I call it a Theragnostic system. We're doing therapy with a microbubble and imaging with the same array, one single array, one single scanner. So I will now present you how we came up with this system and how it is today performing. First, I mentioned that we are going to use microbubbles. We're not only going to use them for therapy, we're going to use their double potential in ultrasound. Indeed, first, they can be used as contrast agents. For example, in liver here, they're used and injected to the patient in order to enhance the contrast on images by providing, small reflectors within the medium. But also, and I would say most impressively, they can be used for what I was calling super resolution earlier. And with the localization of the microbubbles, you can reach higher level of resolution below the wave. So it's another aspect, of microbubble is that it can also be a mean to enhance drug delivery. So a very different role. And there it can either be co-injected with drugs, targeted microbubbles, or drug-loaded microbubbles. In our case, we will benefit from both of these features by first using it as a tool for 3D contrast imaging, and then targeting in 3 dimensions lipid microbubbles that will be co-injected with drugs. And now the question we would like to answer is, how can we optimize image-guided gene delivery? The answer to this question, depends on three main factors. First, frequency, then space, and time. In terms of frequency, as I said, we want to treat and image. Targeting microbubbles for a therapeutic use requires quite small wavelengths, quite small frequency, high wavelength, quite small frequency, and imaging requires a bit higher frequency if we want a bit better image quality. But also, if we want to detect the harmonics, we need to go above, so twice, 3 times or more, if we can, above the therapeutic frequency if we want to see the harmonic oscillation. So literally, we want an optimized bandwidth. The ideal would be the wider possible, but we will see that it's constrained by the hardware design. Then in terms of space, as I said, to do 3D imaging, we need a 2D rectangular aperture. Before it was done 2D imaging with a 1D, now we go to 3D, we need to add a dimension to the transducer. And since we have a 1024 channel system, we can have a 1024 element array. And thanks to 1024 channels driving 1024 elements, we can address to each individual element one individual time delay. Thus, we are able to design any wavefront that we want. A focus wavefront, a diverging wavefront, a plane wavefront, steering on any direction. So this is going to be a very powerful aspect of this array. So now we know what we want, and actually the parameters I just described are going to greatly influence the geometry of the design. Indeed, we need a high penetration depth since we want a large field of view, and we need a large bandwidth to allow both imaging and therapy. So we fixed a central frequency around 2 megahertz with a 60% bandwidth in accordance to the hardware designers who told us this is possible. And in terms of space, we decided to go with a rectangular aperture, but a bit asymmetric, 4 centimeters times 2 centimeters, in order to have a privileged plane of focusing, a privileged orientation of focusing, and the other one will be a help, and I will explain you how the second dimension will really help improving the images and detection of some lesions, for example. Then we have 1024 element array and 2 to the power n element count in each direction. And actually, this leaves us with 3 reasonable designs, 3 reasonable ways to design our aperture. So either to divide it by 32 times 32 elements, 64 times 16, or 128 times 8. So we had a lot of constraints on frequency, space, and time, and now we come up with 3 different designs that are possible. And which one is the best between those 3? Actually, the way to decide that, we have to look at both orientation, so the azimuthal direction. So this is the main direction I was talking about, principal orientation, and then the elevational direction. So for all of these, we need to assess whether in imaging or therapy, those designs are going to be efficient and what will allow the best possible configuration for our goal. First, we tested that on imaging performance. And the best way to test and to evaluate the imaging performance is to look at a point target that we want, as I said earlier, the less large possible, so the smallest possible, really thinnest. And we simulated, for these 3, so 100 times 8, 64 times 16, and 32 times 32 configuration, we image both in azimuth and elevation. And we can see that depending on the configuration, the grading lobes are showing up earlier or later. The best way to probe that is to plot the lateral resolution and really look at where the grading lobes are appearing. And we can see that the 64 times 16 configuration is offering a trade-off, because here the 32 by 32 will bring grading lobes quite close. And same here, the 128 times 8 will bring grading lobes quite close. And here you see that we are 10 centimeters. So basically they're rising there and it's very far. That will allow 20 centimeters of field of view. We don't even expect to be that large. So here, what we know is that 64 times 16 will minimize the grating lobe impact in both directions. And since we have a double use, we also evaluate that in therapy. And in therapy, the stimulation is a bit different. We're not probing the image, but actually the focusing capability, both again in azimuth and in elevation. So for the 128 times 8, you see how the what we call the one-way point spread function, how the focusing is going to be effective on one way only for 64 times 16 and 32 times 32, sorry. So here, interestingly, we can note that the grating lobes, they don't appear very soon. They appear only here at the 32 times 32 configuration, but still here they're quite strong and here they're not there. So the best trade-off, again, we plot the lateral resolutions to look at that, and we really see that the best trade-off is going to be the same, 64 times 16. Indeed, here we have quite close and quite high already the grating lobes, and same thing here. So in the end, something that could have been predictable is that the trade-off is the intermediate size for both directions. And the final design is thus elements that are 1 millimeter times 0.6 millimeter and 64 on one direction, 16 on the other, which makes an array of around 4 times 1.6 centimeters. Thanks to this array, to this design, we're going to steer in two directions, in azimuth up to 18 degrees and in elevation up to 12 degrees. And this will result in the spatial component of our criteria, that is a field of view at 10 centimeter depth of 11 centimeter wide and 6 centimeter deep here. So it's a very wide field of view, and that's what we wanted. The 10 centimeter depth is just an indication, but we can go as deep as, without any problem, 18 centimeters. So then let's come back to the plane wave paradigm. And as I said, we wanted to transmit plane waves to be able to do ultrafast imaging. Thanks to a 2D design now, we're not only going to steer in one direction, but in two. So in azimuth, we're able to incline to steer the plane wave this way. And in elevation, we're going to steer it the other way, like this. And for each steered plane wave, we create one volume. And then when we sum all of the volumes, it results in what we call the compounded volume with a better resolution than if we had used only one or fewer planes. The big question here is how many plane waves should we use? Actually, literature has worked that thoroughly, and it says that it does depend on the steering angle, width of the array, and wavelength. So in our case, with our geometry, it's 45 plane waves in azimuth and 17 in elevation. These will be the parameters that we are going to use in all the following of the presentation. So now we need to, now that we have the transmission, we are able to go ultra fast. We need to look at then, once we have transmitted and received, how do we build the image? Actually, this process is called beamforming, and it does what it says. Starting from the RF signals that are received on the probe, it's going to form back the beam of the wave, and this will lead to the B mode image that we know. How this is done, it's a simple algorithm that has been used for years and years in ultrasound called delay and sum. And all current clinical devices rely on this algorithm. So you have to choose a voxel in your reconstruction grid, and this voxel will have an echo. This echo is received on the probe and inside the RF data that I have talked about earlier. But from this voxel, we are able, since we know its position on the grid, to compute a time delay, that is the round trip from the array to go to this voxel. And once we have that round trip, we can compensate the signals, the numeric signals, to align them. Once they're aligned, we can sum them coherently. That's the way we say just because they're in phase. And the current sum directly gives the voxel intensity on the image. So it's pretty simple for an operation. That is, we have a voxel, we compute the round trip light, we realign the signal, and then we get the intensity. But this has to be done for all the voxels of the volume. And we saw that the volume was large. So here, the limit is really going to be how fast are we able to do this image formation process. And we have some keys here and some factors on which we can play, some others that are quite restricted. So first, on the 4 different systems, we're going to transmit and receive. This will lead to the RF signal. This times limit here is driven by the number of elements fixed on the probe, the number of plane waves, we optimized it, so we had a good image quality. That's it. The PRF highly depends on the scanner itself, and the depth, this depends mostly on the application that we are targeting. So here, now that we have set up all this, we don't have much control. Then the data, this RF data is going to be transferred to the host computer. This again is mostly a hardware thing. But we have a lot of power on the beamforming process that I just described. Indeed, the beamforming process, delay and sum approach, is going to be performed individually on each 4 of the systems on their graphical processing units. That means it's going to be highly parallelized between the different voxels. And then it will retrieve beamformed volumes, 4 of them, because on the 4 individual systems that we put for a problem of size memory, handling on their complex form IQ. And once we have that, we're going to transfer all of them to the main computer and to the primary system. They're going to be summed and displayed. So here, having 4 parallel systems and graphical processing units allow us to have a very high level of parallelization, and with large volumes like deep imaging in the liver, we reach imaging rate of up to 50 Hertz. Why is that important? It's because it's really important for the clinician to be able to move the probe and have real-time response and move fast. And actually, it has to be higher than the eye resolution. So now that we have all this and that we set up the system this way, we can show how the system performs first in vitro on a commercial phantom. And you see that when sliding the plane, the imaging plane along the volume, we can image really different parts. And you see it here as well, so in both directions. And then here, what is really crucial, I said it earlier, is that we have a 2D system, so we're not focusing on one direction. We're using the 2 directions that we just saw. And if we compare 3 different images of the same phantom, spherical cyst phantom, with different focusing qualities. So first, we use only the azimuthal focusing, then only the elevation, and then both. What we see here, if we look at precise cysts, for example, these ones, or these ones, is that, yes, we have an increase in contrast when we use both steering and both focusing approaches. But most importantly, besides being able to image through the volume and through different slices, there are some cysts that we were almost unable to detect, and that now we can access to. So these cysts are a bit below 3 millimeter diameter. So there are small lesions that we would be willing to detect. And what we know here is that having added the elevation focusing capabilities allowed us to improve the contrast, but also detect some cysts that were almost unseeable before. We also tried the system in vivo on healthy volunteer on liver. And here, what's interesting is that in real time, you have access to multiple slices. And so you can choose the number of slices. Of course, it will have an influence on the imaging rate, being limited mostly by the time to display them, but up to 5 to 8, it's okay. And you see here that you really have access to different levels of imaging within the liver, and you can really see different structures but on the same image at the same time. And all this, again, as I said, in real time. So in vitro, we also were willing to assess the capability of imaging in contrast enhanced mode. Contrast enhanced mode is also called CPS, contrast pulse sequence, and it consists of imaging now not only the medium, but focusing on the nonlinear oscillation of the microbubble. To do so, I designed the setup with a PVA sponge in which silicon tubes were inserted, and then I made some microbubble flow in there. And here, if you look at the B mode image versus the CPS image, here you have some speckle around coming from the PVA, the tube reflection, and on the CPS, you only have the signal coming from the microbubble. So here you have a huge contrast gain thanks to the CPS. And what's interesting is that you can have some volume rendering and some volume rendering of the contrast enhanced imaging. And what is this useful for? Actually, to explain that, I want to rely on an example of a collaboration we're having where triggering and imaging bone tissue regeneration has already been proven in 3D. So let me just come back to the background of this project. It consists of, inside a bone fracture, injecting some microbubbles, plasmid DNA combined, and then focusing some ultrasound on these bubbles. And they have proven that within 8 weeks after transfection, the in vivo bone regeneration occurs. So this is a technique that has been proven to be efficient with commercial arrays in 2D. But bones and plates are really challenging the ultrasound guidance, and especially when it comes to bigger animals. So here it was a mini pig, but when it's no longer mini pigs, it's already challenging. So we can just only imagine how difficult it's going to be in humans. That's why we are willing to use 3D imaging and steering to have a better ability to do that. And to do so, we will need the contrast imaging that we just described. So I created an experimental setup in water of this bone fracture, and I used the actual surgical plates they're using in surgery and placed silicone tubes within a PVA sponge. The PVA, again, is here to create biological-like scattering. And here, what we see is that in real time, you're going to see the injection of the microbubbles and how it shows up. So in 2 planes, X, Z, and the perpendicular one, YZ, azimuth elevation. And we see that now that we inject, we have mostly, almost only just the plate's reflection, and then the actually quite narrow, the microbubble diffusion. So again, we have a huge gain in CPS compared to B mode. And what's interesting is that you can render in 3D pretty easily now. In B mode, it's complicated to have proper 3D renderings, but when you have strong reflecting targets as microbubbles, it becomes much easier. So the strong reflection of the plates here, they don't affect the microbubble signal because we have this capability of steering all around the plate. So it also, of course, depends on the placement, but still the high steering capabilities doesn't create the artifacts that they were seeing with one-dimensional arrays. So then what's the therapeutic approach to use this probe and focus on the microbubbles? So since the single focal spot size is around 1 centimeter by 1 millimeter, we wanted to treat a larger area around 2 centimeters. So we were sweeping the focus beam and back in. So if we look just as a schematic representation, this is what happened. We're focusing and sliding. And it's a cylinder, what we call a cylindrical focusing all along the dimension of the fracture. So here we can take a look at how it works. So ex vivo, this is on an actual mini pig fracture. We assess the microbubble sonication and the effect of our focus beam on the microbubble. Here, the way we did that is in the voxel, we counted the number of voxels in which they were above and certain threshold of microbubbles. So here we're counting the voxel with high number of microbubbles in it. And this is what you see here. This curve tells us, okay, with the exposure time, the number of microbubbles inside one voxel are going down. So there are two possible explanations for that. They're spread out, but either they are bursted or they're just spread out. In any case, it's an encouraging sign of stone operation. And what's also encouraging is that when we look at the row signal, so this is a time signal and this is a Fourier signal, we look at the amplitude here and we see that in the presence of microbubbles, we have harmonics appearing in the Fourier spectrum. So we are imaging the nonlinear oscillation. And as I said, that's what we are interested in when we inject microbubbles mostly. So now, besides that, we are trying to extend the use of large arrays in clinical ultrasound. Particularly, the 3D Theragnostic system that I just presented is now developed, and we need, in order to confirm that, to validate the ex vivo data that I just showed. The only way to go forward considering that is to evaluate the transfection. And so we have here a proposal of 3D ultrasound setup, and it consists in having a scaffold in which the cells will be seated in a small duragen, itself embedded in gelatin, and we're going to do that, to do the whole process that we said, so imaging and therapy at the same time. And then the reporter gene detection will be performed ex vivo. So the duragen will be extracted from the gelatin and the cells will be imaged ex vivo by optical microscopy. And the objective here is to quantitatively confirm the transfection, because for now, even if it seems quantitative, actually in terms of transfection, it's just a qualitative assessment of the microbubble quantity. But a wider question that we want to answer and that the team has been working on, I think the past years, and will be working on the coming months and years, is how can we optimize 1024 channels to detect small lesions? And to answer that, there are different ways. First, we can improve the image quality of existing design. Then we can add some spatial degrees of freedom. And finally, push the limits of ultrasound array designs, as we've already been doing it with the different setups I presented. So how to improve the image quality of existing design? An interesting problem in ultrasound is aberration. Aberrations are heterogeneous sections of some medium that induce strong wavefront distortion, and they generate degradation in the images. So because the wavefront is distorted, the delay and sum approach I presented is no longer valid, and we have strongly degraded images that we aim at correcting. A way to do so is aberration correction. And since we've been talking a lot about imaging fast, this was one of our criteria at the beginning, if you remember, imaging fast, we want a fast approach. And during my PhD, I developed an approach that I called SVD beamforming, that is actually allowing ultra-fast aberration correction in 2D that I'm willing to apply here in 3D. Basically, the objective is to perform imaging with plane waves, create one volume with each of the plane waves, and then to place them in a single matrix. On one dimension, all the voxels, and on the other dimension, all the transmitted angles. So we are no longer summing, compounding as we're doing it, we're keeping all individual transmissions. And by doing a singular value decomposition and retrieving only the first singular vector, we are able to isolate the voxels for which the plane waves are coherent between themselves. This means something pretty simple, is that if you're looking at one particular voxel in that final corrected volume, it will be seen by all plane waves the same way. That is what optimized coherence means. So I'm already working on implementing that, and we have promising results, but what will be interesting is to look at how it behaves in vivo and on difficult to image patients, especially in the case of the liver. Sorry. So then the second possibility was to add some spatial degrees of freedom. So again, this is being evaluated today in the laboratory by, for example, rotating large phase array design, And also in the coming months, the ring array that I was presenting is going to be mounted on a translation stage. So adding these spatial degrees of freedom will allow 3D images with 2D arrays. And finally, push the limits of ultrasound array design. So I presented you the technologies, and I really believe that where we are today in ultrasound imaging is like the ultrafast imaging concept has been allowed by the development of highly parallel processors. And now the next revolution in ultrasound is going to be the ultrasound array design, since we already have 1024 channels. So we need to push the technology here forward. And we see in our daily work that the limitation today is here. So an option that we have and that we are exploring is to duplicate the array that I presented to you. That is actually only the first step towards even larger arrays. So here is the example of this array duplicated 4 times to add both aperture and elevation focusing capability. And if you look at the design of the array, actually the challenges are lying a little bit everywhere. So in the boards that are controlling, in the integrated circuits module, also in the flags that are connected with the integrated circuit module to the acoustic module. And we are working closely with manufacturers to really understand their challenges and our objectives and let them meet together. So the idea will be to increase the number of elements, but I said that we will keep 1024 channels. So we will have either to multiplex the channel or include micro beamformers within the array. So they will perform part of the beamforming process I showed you only electronically within the array. And finally, one application that is really interesting and a hot topic for us is application to breast imaging. We would have loved in the past months to go a bit further on that, but due to COVID, recruiting patients has been a bit of an issue. We are still moving forward on this and ambitioning to do some blood mapping, ultrasound tomography, and photoacoustic mapping with the ring array. So this will consist in further developing the technology and engineering the full design of translation as I presented to you. And we already have a prototype in the laboratory. Then assess the sensitivity of the system in rodent models, and then apply it to patients already undergoing some breast MRI. So we can compare the features that MRI brings compared to the one ultrasound brings. But it's not all, and wide arrays have a wide range of clinical applications. For example, in pediatric imaging, they would allow to have multiple organs within the same view. Let's say the 2 kidneys, the whole liver in only one plane of view. Also, abdominal imaging, I mentioned it earlier, but in liver, it can be very challenging since some patients with a disease called NASH can have up to 5-6 centimeters of fat layer. And the problem is not only the thickness, but what is inside is going to highly distort the images. So we need to have good image quality and be able to image deep and in a wide area. And also these kind of diseases are best treated when early detected, and ultrasound is the way to go for early screening. And in the end, plenty of microbubble based therapy can be considered with such systems, from tumor ablation to sonodynamics, BBB opening, or transection, as I was showing. So as a conclusion, we had performance needs, as I said, to widen the use of clinical ultrasound in medical imaging. And here we saw that spatial resolution can be greatly improved and will be limited as of today by the element count, by our capability of driving a high number of elements. The contrast has been greatly improved thanks to the elevational focusing capability, and we're now able to have large field of view and in 3D. The fast imaging has also been allowed thanks to parallel beamforming and parallel beamforming capabilities with the hardware. So as of today, the 2-dimensional and large arrays, they already offer a promising way forward, but that is not it. And there is much more to do beyond it. For example, we need to do, as I said, the ultrasound Theragnostic clinical translation, and we will implement adaptive imaging techniques to our systems, to our pipeline. Also, I'm willing to develop ultrafast Doppler imaging, so using 4D, what we call 4D ultrasound imaging on this system, since we're very lucky, as I said, to have this capability. So, that's something I would like to explore. And then ultrasound super resolution, if we're able to do it, the limit there will be probably the probe itself. And finally, to finish this presentation, I would really like to sincerely thank PHIND, Philips, and Sam Gambir for giving me the opportunity to be here today with a fellowship. And I feel really grateful that I'm working on such hot topics and very impressive science in this environment. So thank you very much. Huge thanks to all the Ferrolab, especially Kathy, who's been supervising me, and also to my collaborators in Sira Sinai. And I will be happy to welcome any of your questions. Thank you very much.
Great, thanks so much, Hanna, for a really excellent presentation, for all your great work. So feel free to either raise your hand and we can call on you, or you can also write your questions in the Q&A for Hanna. Looks like you already have one question, which is, how do you envision the integration of the 1024 channels in point-of-care ultrasound systems where you might not have the luxury of large back-end Verisonic processors?
So thank you very much for that question. It's actually really interesting. For those who have never seen a Verisonic, it does take a lot of room. And so I said we have 4 Verisonics, 4 computers. Basically, it's larger than having 8 big computers. Right now, today, it might not be translatable to ultrasound, clinics as is. But I do believe when you open the box, I have opened the box and I can tell it's almost empty. So I do believe the size is going to be much smaller, and in point-of-care ultrasound systems, we will be able to reduce them to the same size. It's never going to be miniaturized ultrasound, but it will definitely be a reasonable size scanner that you can move around for sure. But it's, again, an important point is that it's a bit more expensive too than what can be done today. So in clinics. So it's an investment, but for much higher image qualities. And for example, in pediatric imaging, where it's really difficult to image children in MRI, it can be very promising to have these tools that are still cheaper than an MRI.
Thanks. Looks like you have a follow-up. Have you considered CMUT arrays for wider bandwidth, especially since you are considering harmonic imaging?
So thank you very much. That's also a very interesting question. Here I showed an image of the probe development, and we are very lucky to have a collaboration with Robert Vodnicki working at University of Southern California. And yeah, he's exploring this possibility too, to have wider bandwidth, because it's the way to go also. But it's always a matter of trade-off between the complexity of integrated circuits and integrated modules and the acoustic modules. So see how it goes, but CMUT are a way forward as well.
I guess we're waiting for other questions to come in. I'm wondering, you mentioned small lesions. Did you have a sense of, what the detection limit would be now with these additional capabilities you have?
So I would love to be telling you the order of the wavelength. As of today, I don't think it's true. I think it's few millimeters. Yeah, you start seeing it at, I would say 1 millimeter, you will start seeing it, which is, I believe, early enough for a lesion. But as soon as we're able to inject microbubbles, some lesions, they're known to be highly vascularized. And then if we're able to inject microbubbles, this detectability limits will go much lower, in terms of size. And hopefully you can do hundreds of microns. So in like the abdomen, it's not necessary, like it does not seem necessary, but in brain, it's really crucial to be able to detect lesions that small.
Right, excellent. Other questions for Hanna? I'll ask another one. I guess, you know, while you mentioned before you're discussing some of this with like manufacturers and seeing how you could implement this, you know, how scalable would this be, you know, if they wanted to adapt it? Is this something they could just make some modifications and plug in, or is, you know, what is the, you know, how deployable will this be as you further characterize this out?
So for the manufacturers of the arrays, actually we're working with them. So we're not doing anything they're not capable of doing. So they should be able to produce the probes without any problem. Then the question is the scanners that are to which the probes are connected. And that's for now, to the best of my knowledge, none of the big manufacturers of ultrasound scanners are going to that level, to that number of channels. So this is going to be the main limit as of today, because the scanners we're using are research scanners. I know in some countries they're being approved for clinical use, but I think right now this is the limit. And I think in the future it might take 5 to 10 years, but the big companies will increase the number of channels that they use.
Excellent. Any other questions for Hanna? I guess another question could be, you know, because you have additional capabilities now, are there other disease areas that this opens up that you're thinking about going after that you haven't mentioned yet as part of your talk?
Yes, that's interesting, because yes, I just mentioned it very briefly while answering to one of your questions. For me, it's brain. Right now, I think here many people must be familiar with some focused ultrasound treatment on the brain using, you know, big transducers. But imaging in the brain is actually very useful, and it can be done through the temporal bone. But the limit here, and that's what I was saying at some point in my presentation, I'm not in the field. I've been in the field for like a bit more than 4 years, so I'm not very old to the field, but enough to really feel the sense that the next revolution needs to come from the probe design to be able to go through the limit of the bone. We have means to correct aberrations. We have worked on that a lot, but we need arrays that will allow to have sufficient propagation, sufficient pressure waves going through the bone itself. So I really think there is a lot to do in the brain, and it's also a very challenging and hot topic in the ultrasound community.
Excellent. Looks like we have a hand up. Daniel, please go ahead.
Yes, so about 25 years ago, we worked with Hewlett-Packard Corporation on a parabolic array of transducers that was focused to treat deep-seated pelvic and abdominal tumors, and we treated patients on it, and we published our results. We thought the limitations in the brain were the bone, and so if you wanted to use it at that time, you had to do a bone flap to prevent the reflection and the heating that we got at the interface. So that was 25 years ago. It's nice to see people are now really making tremendous progress in extending that. I think the parabolic distribution has an advantage. Your beams are already focused at the center of the parabola. So if you have a deep-seated pelvic or abdominal tumor, you put the patient in this water bath and you focus right through it. I think you may want to look at some of those old publications. We had a big program project grant for about 20 years at Stanford to do all types of deep-seated tumors with both ultrasound, and did the same thing with microwave arrays.
Oh, thank you very much for the suggestion. And yes, I agree. The bone skull bone is really challenging because we don't want to overheat, and it's posing much more challenge than just through the skin. So thank you very much for the suggestion. I will look it up.
And the other limitation we ran into was air in body cavities. So if you were trying to treat a tumor in the pelvis and there were loops of bowel with air in them, you got reflections off the air, limited your penetration. So that's another problem. You may be able to better work around with your arrays. Like you can work around the metal plate. We couldn't do that.
Yeah, and also the fact that we can, image and treat with the same array offers us a lot of flexibility, because we really have no time delay between, like, we can just treat, stop, image. I mean, it's really real time and simultaneous. So it does offer a lot of flexibility in the process itself.
We actually worked out the thermal dose response for both tumor destruction and for normal tissue toxicity. I mean, we literally did hundreds of patients back then. So
oh, wow.
Lots of old data resurrect from 25 years ago.
Thank you. I will definitely take a look to that. Thank you.
If you have any problems, just contact me. I can send you the references. They're fairly widely published, probably in a journal you don't know about. It's called the Journal of Hypothermia.
I heard about it in a microbubble imaging and therapy. It's pretty well known.
So everything cycles. It's nice to see things cycling back. Thank you.
Thank you very much.
It looks like we have one last question. Have you seen any pathology on the tissues when you're using microbubbles for diagnostics, hemorrhage or edema, for instance?
So thanks a lot for the question. I haven't personally seen those pathologies, but I know in literature and in people doing experiments around me with microbubbles, we can see them. And really here, the challenging effect, and I'm actually experiencing it with my bone fracture experiment, is to dose the power of the ultrasound, of the pressure that we're going to apply. Because if you apply too much of pressure, you can create cavitation that will damage the tissues. If you don't have enough pressure, you will have no effect. You will not generate the transfection. So it's really a matter of the mechanical index that is going to be applied to the tissue, and definitely it can lead to some damage. And in the very impressive experiment that, for example, Kim But-Solly's group is doing for focused ultrasound, the process is, when working on patients, for example, for essential tremor healing, they first try it and stop right after to see if they created, when they overheat at some area, they created a defect or a damage. And I think it will also be a way to go here. We really have to assess as soon as we do a bit of pressure, just check that the tissues are safe, because definitely we can harm them with too high pressures. Here, as though I have a limit, is that my probe, as it is developed, will overheat if I send too much pressure. So it should not be a problem here.
Excellent. Thanks, Anna. Well, thanks for an excellent talk and sharing all this great work with us. Really impressive, and keep us posted. And thanks everyone for joining us. We're really a pleasure having you today.
Thank you very much. It was really great to present to you. Thank you.
All right. See you, everyone.
Goodbye.